All right, here's our pain and performance video number 2. Hopefully you got some good information from video number 1. This first topic I'm going to talk about is kind of a sensitive thing. It's kind of tough sometimes for me to, say it to people and not offend them, but also be stern about it. And basically, your pain is your responsibility. And the thing is, you have a lot more control over it than you may think. Unfortunately, a lot of people have given up hope. And there's a concept called learned helplessness. And usually it stems from a couple of different things, but people have gotten misinformation from people. People have seen other practitioners that have given them scare tactic diagnoses, such as bone on bone or disc herniation, or you need surgery, or this will never get better, or if you don't take this drug, you know it's going to get worse, or you can take this drug and it's going to get worse anyway, so you're going to have to take another drug. And I've through my 21 plus years, I've seen most most conditions, and a lot of them, the people that want to get better will get better if they take the time and figure out a game plan to do it. But the ones that have given up hope and just think listen to the scare tactics that they've been given are usually the ones that don't get the results that they want. A lot of times I go back to parenting style. Unfortunately, is you probably have noticed this. There's kind of two types of parents out there. There's those kids that fall down and then right away they look for their parents. And there's kind of two types of parents. There's one parents that are run over and say, "Oh, you're okay. Oh, no, no, what's wrong? Everything's okay." They really pamper the child. And then there's the other parent that looks at him and says, "Get up, rub some dirt on it. You'll be fine. It's just a trip and fall. You didn't break anything." And it seems kind of weird, but if you notice, there's you see that a lot. And so a lot of times when you see the kid fall down, they don't even cry or really react. The first thing they do is they look at their parent for what the parent is going to do. And if the parent looks scared, shocked, and runs over in concern, then you see the kid start crying hysterically. And if you see a parent that kind of looks at him, says, "You're all right," kind of looks him over and makes sure that there's no broken bones, I mean, that usually those kids grow up in two different fashions. A lot of times the kid that was really pampered ends up, you know, having far more conditions that concern them. They have a lot more of this learned helplessness where they feel like, unfortunately, woe is me, or I'm not going to get better, or and a lot of times they're the ones also looking for advice from all sorts of practitioners, and then they're looking for the ones that are going to give them negative advice or some scare tactics, and they use that more than practitioners that give them positive and hope kind of thing too. So unfortunately, a lot of people develop based on their parenting style there, and some scientists kind of use that premise as an example, and it sounds kind of bad, but they took dogs and they shocked them. They put them in a cage, a closed cage, and they would shock them periodically, the floor. And of course, that would shock the dog. And then over time, they just continued to shock these dogs and leave the cage door closed. And then they decided to open the cage door, and they shocked the floor again. And instead of running out the cage door, the dogs would just stay there and absorb the shocks. And most of these dogs would never even leave the cage. They would just sit there. And that's where they kind of supported this theory of learned helplessness, where the dog's like, my life is just about being shocked, and there's nothing I can do about it. I can't make any improvements, and I'll just sit here and continue to live my life being shocked and tormented like that. So terrible experiment, especially if you love dogs, but it kind of went to prove this the theory that that our brains can be programmed to either not want to get better and kind of give up, lose hope, or to make a change. So these are the three questions I always want to ask my patients, and you should stop and think about it right now. Do you really want to get better if you have a condition, especially a chronic condition? That's an important question to ask yourself. You would think everybody would, but like I said, if you have this learned helplessness, the answer might be no. You just think you're not going to get better, so you don't even think it's an option. So which leads to question number 2 is, do you think you can get better? So do you want to get better, and do you think you can get better? Kind of the same thing, but two different things. And if the answer is yes to both those, you want to get better and you think you can get better, or even want support from us to make both those questions yeses, if all humanly possible, then how much time a day can you set aside to work on your health? And some people say nothing, I'm just too busy, which I don't think you're going to get the results you want from that. Or other people are like, I could do 1 or 2 hours, which is more than we need. What we ask for our patients is just small 90 seconds to 180 seconds every couple hours. So maybe 8 times a day for just these small, short spurts of exercises is enough to retrain the brain to make positive changes. Like I said before, research shows that just 20, 30 minutes, 3-minute sessions per week is more effective than 1-hour sessions. So think about that. I want to go back to this pain model that we talked about in the first one, and we're going to go over these 4 concepts in the next couple slides here real quick. Now the first thing is, pain doesn't always usually tell us where the problem is based on that. So the brain is really good at trying to get your attention. And again, the reason we have pain is an output from the brain, and usually it's an accumulation of dangers. So once there's evidence that danger maybe is outweighing safety, your brain will give you that sense of pain. It's this way of getting attention. That's why a lot of people have low back pain, is because you have a lot of mechanoreceptors. It's the most dense area of mechanoreceptors in the body, and so it can get your attention by limiting your motion down in your low back, because the mechanoreceptors is the receptors that help you move. But pain is also influenced by many factors, from everything that you see, feel, the people around you. And usually there's many different threats at the same time that create a protective output. And so, with these 3 concepts, usually that tells me that we need to look at a lot of different places than just if you come in with knee pain. We're going to go over that here in a second, that there really is no one specific thing that causes knee pain, but it's your environment is causing your brain to feel threatened and in danger, so it's going to get your attention by giving you pain. There's a lot of different factors that play a part in there. So our job here is to look at all those different protective outputs that your body's giving you, such as muscle spasms, restricted motion in your joints and your spine, maybe even some depression, anxiety feelings you're going through, tingling sensations through the nervous system, brain fog, and mental cognitive stuff, and then even compulsive thinking patterns there. So like I was saying, there's science researchers tell us there is no such thing as knee pain. I mean, obviously people feel pain where their knee is, either the right knee or left knee, but you and I can both have the exact same condition on an MRI, an X-ray, you even have the same injury pattern, but pain is processed in all these different areas of the brain. So say we both got kicked in the knee, and I'm not a MMA fighter, but you are. So when we both get kicked in the knee, you're gonna have a different area of your brain, because your brain has already been kicked in the knee multiple times. If you've been practicing as a fighter, you've been kicked and you've been taught how to take a kick and how to react after a kick. Whereas I have never been kicked or trained to be kicked, or even wanted to be in some profession that kicking is a regular aspect of fun, I guess. But so you and I are both going to respond differently to being kicked in the knee. We both might have some sort of pain afterwards. We both might have a bruise there, but mine might be sore for the next 2-3 days, and yours may not even have pain, or for a couple hours, and you rub it off with some dirt, and everything is fine there too. So you can just see here, we're not going to go through all this, but the brain processes pain in all different areas of it. Most of them start through that brainstem. We're going to talk about that more in videos on how we can decrease pain by stimulating the brainstem, but goes up through the spinal cord, through that brainstem, and then branches off like a spider web in all different directions. So how we look at pain, again, is through the 8 models. So I mean, your knee pain could be receptors, nociceptors or stretch receptors or pressure receptors in the knee that need rehabbing. It could be the peripheral nerve. It could be the nerves going down the knee. It could be a problem in your low back, which then starts the sensation down to the knee. It could be a coordination issue. Every time you walk, your right knee isn't as balanced or coordinated as your left knee. So it could be a cerebellum problem, could be a brainstem problem, like I said, where the pain is processed. So maybe one side of your brainstem isn't inhibiting pain like it should, and so you have more pain on the right than the left. Could be the thalamus, which is the gatekeeper that kind of tells the rest of your brain what's important or not important. The insula could be a referral from your liver. Your liver could get detoxed or be detoxing or inflame the tissue around it, and it could be referring down to the knee. Could be your cortex, the outside, the top part of your brain that, your voluntary movement isn't very good on the right side compared to the left side. So it could be any one of these things causing knee pain. So you may get a diagnosis of bone on bone in the knee, or meniscus tears, or this and that. And I've seen all those, and I've seen them all go away, the pain go away in all those by addressing these. So that's what we're going to look at a lot with our patients, is a different approach to knee pain. And a lot of these, we're not even going to, we may address a little bit of the knee, but the problem is either above or below the knee. In fact, probably, 70, 80% of my knee pain patients, we get rid of their knee pain by going at the ankle, and the ankle is immobile like it should. So after doing some mobility drills with the ankle, their knee pain clears up. Which then kind of leads into movement. Our number one job of the brain is safety, like we talked about in the last video. The second job is movement. And usually we use the concept of we need to increase movement in order to get pain, which equals pain relief or pain to go away. We're not going to get too in depth with it with this video, but you have three main parts. You have the frontal lobe, which initiates beginning of movements. You have the cerebellum, which does coordination, balance, accuracy of the movements. And then you have your midbrain, or PMRF, that controls the tension of the muscles and controls the muscles of flexion and extension. And if you don't have a good balance there, you're going to be prone to injuries or restrictions in motion. So later on in videos, we're going to go into these in depth, what they all do. But again, if you go back to the job one of your brain, it's safety and protecting you from danger. So one of the things it does is protects how much strength you can have. So they find that most people only use about half of the strength to a third of the strength that their muscles really could use. So if you're curling, you may only be able to curl half of what your body can. So that's why you hear those stories of little grandma who has to pick up a car that fell on little Joey, and then they realize the car is just extremely heavy, obviously, and so the brain will sometimes, in certain circumstances, let you kick into that full, closer to that full 100% of its capability. But otherwise, we go through life with a dimmer switch on our muscles. And so it gets even lower when we have joints that aren't moving or areas of the body that the brain feels threatened. So if your right knee is giving off pain sensations, or you think you have pain in your knee, your brain might even lower the strength going to that knee. So a lot of times our number one goal is just to get one pain-free full range of motion of that right knee or whatever knee is hurting, and then that creates a cascade of relaxing of the brain, and it feels less threatened, and then it gives the strength back. And again, we look at a lot of different things in order to get that pain-free motion. And so it's kind of more complicated than just saying. So there's a concept called arthrokinetic reflex. Most of you who've come into the clinic, I've demonstrated this on you, where you lay down face down, and I tested your hamstring strength and showed how weak it was. And then I mobilized your ankle just a little bit, kind of twisted it right and left, and did a little distraction. And then we retested your hamstring, and it was sometimes twice as strong as it was. There's 52 bones in just the foot and ankle. So if all those little joints are stuck or not mobile, it's a big area for the sensory part of your brain and the motor part of your brain to create blurred maps in there, which we'll talk about in another video. But basically, when you have these blurry maps, the brain is going to go into a protective mode and decrease the strength of the muscles around that joint. So one of the main things we work on with people right away is just getting mobility and having your brain be able to move all your joints in all the different directions with all the different motions. So you'll see on our floor we have kind of a compass thing. We have you go into all these different directions with your toes and ankles and knees, just to remap your brain. I don't know if you've ever had that where you're walking and all of a sudden your knee just kind of buckles. There's a good chance that it did that because you kind of did a motion or a step that your brain didn't have a map for, and so it just kind of went weak on you, or almost paralyzed for a second. So, which is not good because then things tighten up and you're more prone to injury. So, mobility is one of the biggest things. This is a concept we use, is what's called arthrokinetic reflex. So that's something we'd work on when you come in. You can see from this slide, these are just all the different mobility things we do just with your ankles and your knees and your hips. So this is something that we have demonstration videos for. I just got these pictures from Z Health training just to demonstrate the different parts of the legs that we're going to be mobilizing. And one of the other big things we look at is your gait, your walking patterns. Why this is important is because everybody tends to walk anywhere from 5 to 10,000 steps per day. And if we do a bunch of exercises and adjustments and muscle work, but your walk is off, and we'll show you more videos of different walking patterns that are off in future videos, but you can see here on this picture, every time you step, as soon as your heel touches the ground, and usually only one foot is on the ground at one time when you're walking, there's an energy force that goes up the side of your leg to your knee, which then goes up to your SI joint. Your SI joint will actually lock there to transfer energy over to the other side. So you can see the energy through your body is going to transfer to the other side and goes up all the way up to the jaw and to the arm. And we use this as there's a concept called opposing joint, where this shoulder works with this hip. We'll talk about that more in the future here, but you can rehab these opposite joints based on this, transfer, back force transformation or transmission system through there. But if any one of these joints is not moving, not functioning right, or maybe the muscles on the front are overactive versus the muscles in the back, it's going to affect your gait or your walk. If there's parts of your brain that aren't functioning right, your arms are maybe going to turn in, your leg might turn out, may turn in, your shoulder might protract or go forward, your shoulder might go up, your head might bobble or go back and forth with each step, which will cause dizziness and vision problems. So I usually use this alignment of a car example here. You can see on the tire how the tread on the car gets worn out when the alignment's off on the car and the car is constantly pulling one way. Same thing could happen in your body. You can have alignment problems that wear out your hip or your knee or your ankle joints faster, and sometimes your body will go into protective mode and actually lay down extra bone, and that's when you get arthritic changes, or what they call degeneration changes, but they're actually your body doing the opposite. It's trying to protect itself. It's being proactive and trying to strengthen a joint that's not moving well. But the key is with this slide here is, if we're going to change your walking pattern, it takes, we won't go into this too much here, but the Posner model here says that you need to do something, particularly like with walking, 100,000 steps in order for it to become a muscle memory or become a normal pattern. So, you can't just walk for a day or two. It's going to take time if you get 5 to 10,000 steps per day. But if you've ever broken an ankle and had to wear a brace or a walking boot for 4 to 6 weeks, it went up to that 100,000 steps, and then you might have created a improper gait or walking, and you might have created a cascade problem up your back from rehabbing for 4 to 6 weeks. So if you never fully rehabbed your all your muscles, your joints, after an injury that you might have had 10, 20, 30 years ago, you may have been walking around with a bad pattern for all those years and not even known it. I mean, your bone that you broke healed up, but it created a bunch of other pattern problems all the way up your back, and maybe your TMJ, your jaw issues, are coming from an old injury in your ankle. The other factor we look at is your SI joint when you walk. I'll get to that too, but here's just a quick little thing. The 4 main characteristics we look for when we're watching you walk is a bobblehead. Does your head bounce back and forth, or does it stay still like it should? Do your muscles make your shoulders roll in and your hips roll out with the PMRF problem? Do your arms move equally when you're walking? So you should have a equal swing. So just watch some people. You can see one arm kind of swings back and forth and another one hangs down. That's a frontal cortex problem. And you should have some coordination when you walk. You'll see with cerebellum problems, the feet will turn in and people will kind of stumble or their foot will cross the midline of their body when they're walking there too. So those are, we're going to go in more depth with other videos, but those are 4 concepts that we look for. And then the SI joint here is the last thing. So, when you walk, because that energy pattern crosses over the body, your SI joint should move. So kind of 4 categories to look at. Sometimes the SI joints don't move at all on certain people, on a lot of people. And that means their low back's going to have to rotate because they're not getting the rotation in their SI joints. And they have all sorts of low back problems, pain in their back. The other one is the hips go up and down, which could be another problem where, you're going to have to kind of twist in the low back. You're not getting the rotation in there. Number 3 here is when the hips go side to side and kind of a waggle to them with that. So that's going to create some other issues. So all these could create more issues on some people than other people, but they, a lot of times explain why people have headaches, and jaw pain, and shoulder problems, and hip problems, and ankle problems, and knee problems, all based on their walking. So you can do all the exercises, stretches in the world, but if you don't fix what you're going to do the most of every day is walking, then your problem's just going to keep reoccurring. Now, last little slide I like to show here is a spinal nerve function, just so you know where the nerves, you got the cervical nerves in the neck, the thoracic nerves in your rib cage, mid-back area, and you got the lumbar nerves. And these are just a chart of where those nerves go to, which organs they mainly control. And then, of course, those organs give off symptoms if they're not working right. And so through the years, I look at this and I think I've helped every single one of these conditions with people, even down to like hemorrhoids. I don't know how many multiple people have come in and said, man, I used to get hemorrhoids and now I don't. And that's not something I promote as a hemorrhoid relieving clinic here, but it's just if the nervous system's working better, the organs will work better, and then those symptoms that you've learning to live with will go away. Without medication, your body will heal itself. So hopefully this helps. Any questions, get a hold of me. Thanks.